Welcome to the Deep Dive. Today we're tackling a topic that sits in a pretty interesting gray area of medicine, hyperbaric oxygen therapy, or HBO2.
Right.
We know it's got some really well-established uses, but, well, what about beyond those? We're diving into the world of off-label indications for HBO2.
Exactly. And for this, we're drawing from the textbook Hyperbaric Medicine Practice, specifically the chapters looking at off-label indications for hyperbaric oxygen therapy.
Okay.
So think of this as getting, the inside track on the science, or sometimes, frankly, the lack of science behind some of the more, let's say, debated uses.
Okay, off-label straight away. That sounds a little, maybe a bit murky. What does it actually mean when we're talking about HBO2?
Yeah, good question. So in our source material, off-label HBO2 means using 100% oxygen at pressures of 1.5 atmospheres absolute, that's ATA, or even higher, for conditions where the scientific proof of benefit isn't really, well, up to par yet. You might also hear people call them unestablished indications or off-list, maybe unapproved. They all basically mean the same thing, uses that haven't really been widely accepted or validated by the medical community.
And the source draws a line in the sand regarding mild hyperbaric therapy, right? Those lower pressure treatments. They're sort of separate from this discussion.
That's right, yeah. The authors are pretty clear on that. They state pretty firmly that they haven't seen reliable clinical evidence that supports any real therapeutic benefit from that mild hyperbaric therapy. The kind using pressures around 1.2 to 1.3 APA and often lower oxygen levels.
Okay.
So our focus today, it's really on the more standard, higher pressure HBO2, but specifically for those uses that haven't gotten the official nod from, say, the major medical craft groups in the Western tradition.
Got it. So we're talking about applications that haven't received the thumbs up from organizations like the Undersea and Hyperbaric Medical Society, the UHMS.
Precisely.
It definitely sounds like there's more to this story than just the raw scientific data.
Absolutely. And a big part of that story is figuring out why HBO2 specifically seems to be such a magnet for these less established off-label uses.
Okay, yeah, let's unpack that. What is it about hyperbaric oxygen that makes it so, I guess, tempting for these kinds of applications?
Well, several factors seem to play a role, according to the authors. First, there's what they describe as this powerful ritual of hyperbaric oxygen.
Ritual.
Yeah, think about it. You've got the specialized chamber, the focused attention from the staff, maybe sharing the experience with other patients who are also hopeful. It creates this really immersive, almost dramatic environment.
Right, it feels like something significant is happening.
Exactly. And for conditions where how a patient feels or perceives their symptoms is a big part of the outcomes, subjective outcomes, this whole setup can lead to a really significant placebo effect, or maybe a participation effect. People feel they're actively doing something major for their health.
It's definitely more involved than just, say, taking a daily pill. There's a whole performance element, almost.
That's a good way to put it. Then secondly, there's the regulatory status of oxygen itself. In some places, how oxygen is classified and regulated as a drug can be, well, a bit ambiguous. And unfortunately, that ambiguity can sometimes open the door for people without medical training to operate hyperbaric units and, make some pretty outlandish claims that aren't backed by solid science. The authors point out the internet is, well, rife with this stuff.
I can imagine. Easy for misinformation to spread.
Mm-hmm.
What else? Is there a third factor?
Yeah, the third piece really taps into something fundamental. How we all think about oxygen. We know it's essential for life, right?
Of course.
So that intuitive jump to thinking, well, more oxygen must be better is actually quite an easy sell to the public. It makes marketing HBO2 for a whole range of conditions much simpler, often dressed up with some, let's say, questionable scientific explanations you find online.
It plays on that very basic biological understanding, or maybe misunderstanding.
Exactly. And then finally, and this is really important, we have to think about the patients themselves who are seeking these off-label treatments. Often, they're dealing with really difficult chronic conditions, maybe debilitating ones, where conventional medicine hasn't given them the answers or the relief they're desperate for.
So they're looking for hope, really.
Understandably so. They might be willing to try almost anything. And that vulnerability, unfortunately, creates an opportunity for exploitation by those promoting unproven treatments.
Okay, so given all that, how do the experts in our source material actually categorize these different uses? It can't just be a simple, yes, it works, or no, it doesn't.
No, it's more nuanced. They suggest a really useful 3-tier system: approved, experimental, and inappropriate. Approved uses are the ones where there's solid human evidence showing it's effective. And importantly, this evidence is reviewed and interpreted by expert bodies, like the UHMS committee you mentioned. It's also worth noting, though, that the amount or type of evidence might vary. For really common conditions, you expect large trials, but for rare diseases, the evidence might look different, but still be convincing to experts.
That makes sense. You wouldn't necessarily need a 1,000-patient trial for something like, I don't know, severe carbon monoxide poisoning.
Exactly. Then you have experimental indications. This is where things get interesting. There's a plausible biological reason why HBO2 might help. Maybe there's some promising animal research, or perhaps some early human case studies or anecdotes.
But not enough proof yet.
Not enough robust, high-quality human evidence to get that approved status. It's promising, perhaps, but still under investigation.
And the third category, inappropriate. That sounds pretty clear-cut.
It generally is. These are uses where there's very little, if any, logical or biological reason to think HBO2 would work. Or maybe there's just no supporting evidence at all. Or sometimes it's been researched properly, maybe even in good trials, and the evidence actually shows it doesn't provide a benefit. And it's really crucial to understand that both experimental and inappropriate indications fall under that umbrella term the authors use: unestablished or off-label.
And the authors seem to have quite a strong viewpoint on actually using HBO2 for these unestablished conditions, don't they?
They really do. They state very clearly their belief that HBO2 shouldn't be marketed or represented as a proven treatment for these conditions. Ideally, they argue, it should only be administered within the structured context of formal clinical research.
And definitely not for profit outside of research.
Absolutely not for financial gain based on their ethical stance.
Which circles back to the potential problems with treating these off-label conditions. We talked about the vulnerability of patients.
Yes, and that's really at the heart of the ethical concerns. Our source references guidelines, like those from the College of Physicians and Surgeons of Saskatchewan, which emphasize the risks of offering treatments without solid proof.
What kind of risks?
Well, creating false hope, for one. Potentially causing patients to delay or even forego treatments that are proven to work. And, HBO2 isn't entirely without risk itself. You're exposing someone to a medical intervention, potentially side effects, when the benefit is uncertain or unlikely. That's a serious ethical consideration.
Beyond the individual patient impact, does this off-label use affect how the wider medical world sees hyperbaric medicine as a whole?
Oh, definitely. The authors argue it can significantly tarnish the field's reputation. When HBO2 gets promoted for conditions lacking strong evidence, it risks making the entire specialty look like, alternative medicine or fringe science.
Not scientifically rigorous.
Exactly. They even bring up a rather pointed article from 1987 in the journal Chest, which famously called HBO2 a therapy in search of diseases. That really highlights the kind of skepticism that unproven applications can generate.
Wow, that's quite a statement. That must make it harder to build bridges with other specialists.
It absolutely does. This negative perception can make mainstream doctors hesitant to refer patients, even for the fully approved, evidence-based indications where HBO2 is genuinely beneficial. It creates barriers. And you see this concern reflected at regulatory levels, too, like the FDA's 2013 communication, warning the public specifically about misleading claims for HBO2 in conditions like autism, AIDS, cancer, stroke, and depression.
Okay, let's maybe zoom in now on a couple of specific off-label areas that are getting a lot of attention currently. The sources flag chronic head injury and post-concussion syndromes as a big one, particularly in the military.
That's right. There's been huge interest, especially in the U.S., around using HBO2 for the long-term effects of mild traumatic brain injury, MTBI, often seen in veterans.
And what did the early research show?
Some early studies, like those by Harch and colleagues and another by Churchill, did report some positive findings. They saw improvements on neurocognitive tests and also changes in regional brain blood flow measured by SPECT scans.
So, encouraging signs initially.
Encouraging, yes, but, and this is a big but, these were mostly observational studies. They lacked the rigorous controls, like a proper sham group needed to really prove cause and effect. You saw subjective improvements reported, too, which always raises questions about placebo.
And then the U.S. military stepped in with more rigorous research.
Yes, exactly. They funded several large, randomized, double-blinded, sham-controlled trials, key studies from the Army, the Air Force, and the Navy to really dig into this.
The gold standard approach, what did they find?
Well, despite some variations in the treatment protocols and the sham procedures used across the studies, the overall conclusion was pretty consistent.
Which was?
HbO2 therapy didn't show a statistically significant benefit compared to the sham treatment group for the main outcomes they were measuring in MTBI patients.
So no clear advantage for the real thing over the placebo or sham.
Essentially, yes. Interestingly, in the Army and Air Force trials, both the group getting HbO2 and the group getting the sham treatment showed some improvement over time.
Suggesting a placebo effect.
That's the most likely interpretation, yeah. A significant placebo or participation effect seemed to be at play. The Navy study actually didn't show that same level of improvement in either group, adding another layer of complexity.
So the high hopes from earlier studies weren't really borne out by these more robust trials.
That's how the authors interpret the bulk of the evidence, yes. But it's not quite the end of the story for proponents. They've raised a counterargument about the sham controls used.
What's the argument?
The main point is about the active air sham used in some trials. This involved putting the control group in the chamber and pressurizing it slightly, maybe to 1.3 ATA, while they breathed regular air. The argument is that even this small increase in pressure might actually be therapeutic, meaning the control group wasn't truly inert.
So you can't really compare HbO2 if the comparison group is also getting some kind of treatment.
That's the claim. But the authors of our source material push back strongly against this. They argue there's no solid scientific evidence showing that just breathing air at 1.3 ATA has any real neuroprotective or healing effect in MTBI.
Plus, they make the point that the tiny increase in blood oxygen you get from breathing air at 1.3 ATA could easily be matched just by breathing slightly oxygen-enriched air, say 27% oxygen, at normal sea level pressure.
Without needing the chamber at all.
Exactly, without the risks, costs, and complexity of hyperbaric exposure. And that simpler approach hasn't really been shown to work either.
It feels a bit like moving the goalposts to explain away the trial results.
That seems to be the author's perspective. They also address the broader argument some make, that any pressure change, even just the sensation of it, makes blinding impossible and therefore invalidates all sham-controlled HbO2 trials.
A circular argument, almost.
Kind of. The authors reject this. They say, look, when multiple well-designed blinded studies, including ones that carefully controlled oxygen levels in the sham group, show similar improvements in both the HbO2 group and the sham group, the most logical conclusion isn't that the sham is active.
It's that the HbO2 isn't adding a specific benefit beyond the placebo participation effect. Precisely. They even include a figure in the text showing just how unlikely a significant dose-response effect would be from such tiny changes in pressure, or oxygen partial pressure, as suggested by the active sham proponents.
What about those SPECT scans, though? The ones showing improved blood flow in some early studies.
Yeah, they tackle that too. They point out that changes in regional cerebral blood flow seen on SPECT aren't exclusive to HbO2. Similar changes can be seen after effective cognitive therapy, for instance, and even purely from placebo effects in other fields like pain research.
So the scans themselves don't prove HbO2 was the specific cause?
Not definitively, no. They're interesting findings, but they could reflect a general response to intervention and expectation rather than a unique effect of the hyperbaric oxygen itself.
So pulling all this together, where do the authors land on HbO2 for MTBI and related conditions like PTSD or post-concussion syndrome?
Based on the weight of the evidence, especially the consistent findings from those large military-funded sham-controlled trials, they suggest these conditions are moving away from being considered experimental
Towards
inappropriate in their classification system. They argue the most plausible explanation for the improvements seen across different groups in various studies is a substantial placebo or participation effect. They mention this is especially relevant given that cognitive rehabilitation is known to be effective for MTBI. They even reference a flawed, non-blinded study on cerebral palsy where all the groups put in a chamber showed improvement, including one just breathing air at 1.3 ATA, which really highlights how easily non-specific effects can cloud the picture.
Okay, that's a fairly definitive stance on MTBI. Let's switch gears now to another major area you mentioned, ischemic stroke. The sources look at using HbO2 both right after a stroke and then later during rehabilitation.
Yes, stroke is obviously a huge public health issue, a leading cause of death and long-term disability. Ischemic stroke, caused by a clot-blocking blood flow in the brain, is the most common type.
And the standard treatment is all about speed, right? Restoring blood flow quickly.
Absolutely critical. Treatments like clot-busting drugs, thrombolysis, anticoagulants, and now increasingly endovascular clot retrieval, ECR, all aim to restore perfusion as fast as possible. Early diagnosis is key.
So what's the logic behind trying HBO2 in that immediate acute phase after an ischemic stroke?
The core idea is pretty straightforward. Force more oxygen into the blood plasma, get it past the blockage, and deliver it to the brain tissue that's starving for oxygen, the ischemic penumbra.
Okay.
The hope is this could limit the extent of the brain damage, maybe reduce swelling, edema, and potentially have other benefits like reducing harmful oxidative stress or helping restore the blood-brain barrier.
Are there potential downsides too?
Yes, there are theoretical concerns. Too much oxygen could potentially increase oxidative stress in certain situations, or it might even negatively affect cerebral blood flow regulation. It's a balance.
And what has the research shown for acute stroke? Animal studies first.
Animal studies have generally been, well, quite encouraging, showing potential benefits. But there's variability, and often the benefit seems to decrease if the treatment is delayed.
What about in humans?
Before the 1990s, it was mostly just case reports, not strong evidence. More recently, the authors point to a major Cochrane review that systematically analyzed 11 randomized controlled trials looking at HBO2 for acute ischemic stroke.
Okay, what did that review find?
It found quite a bit of variation between the trials, what they call clinical heterogeneity. Different timings for starting HBO2, different pressures, number of treatments, patient populations. Also, many of the trials were relatively small, lacking statistical power.
So pooling them together was tricky. What was the bottom line?
The bottom line on mortality risk of death was no significant difference. Patients getting HBO2 plus standard care didn't fare better or worse in terms of survival compared to those getting standard care alone or a sham treatment.
What about functional recovery? Did people recover better with HBO2?
That was less clear. The review looked at various functional outcome scales. One trial did suggest a possible benefit on disability scores, but this wasn't consistently seen across the other studies, and interpreting those kinds of ordinal scales statistically can be complex.
So, overall conclusion from the Cochrane review on acute stroke.
Basically, that despite the plausible biological rationale and the positive animal data, the routine use of HBO2 in the acute phase of ischemic stroke just isn't justified by the current evidence from randomized controlled trials. They classify it as experimental.
Needs more research, basically.
Definitely. They stress that future trials need really careful planning, especially regarding patient selection, stroke severity, the precise oxygen dose and timing, and importantly, how HBO2 might fit in now that clot retrieval is becoming more common.
Okay, what about the other angle, using HBO2 much later, maybe months or years after a stroke, as part of the rehabilitation process? What's the thinking there?
Right, the rationale shifts a bit. Here, the idea isn't so much about rescuing dying cells immediately, but more about potentially reviving brain tissue that's maybe survived the initial stroke but isn't functioning properly, sometimes called stunned or idling neurons.
How would HBO2 help there?
The main hypothesis is that repeated HBO2 sessions might stimulate angiogenesis, the growth of new blood vessels in these salvageable areas, improving oxygen supply and potentially leading to functional recovery. Interestingly, some researchers, like Efrati and colleagues, have even proposed that maybe HBO2 given too early, in the acute phase, could potentially be harmful, making the later application more appealing.
Has this later stage use been studied?
Yes. The authors mention an older randomized crossover study from the 70s by Sarno et al., which was actually negative. It didn't show a benefit.
Okay. Anything more recent?
More recently, a study by that same group, Efrati et al., has stirred quite a bit of interest. It was a randomized comparative trial. They took people with chronic stroke deficits, month or years out. One group got a course of HBO2. The control group got no specific treatment during that initial period, then later crossed over to get HBO2.
What did they find?
They reported statistically significant improvements in neurological function and brain activity, seen on SPECTA scans. In the group after they received HBO2, compared both to their own baseline before treatment and compared to the control group during the period they received no treatment.
But wait, the control group got no treatment? Not even a sham procedure?
That's the major point of contention. They didn't include a sham control, partly based on that argument we discussed earlier that any pressure change might be active, making a sham difficult.
So how do the authors of our textbook interpret that Efrati study?
They acknowledge the findings show a modest treatment effect compared to no treatment during the same time frame. However, they share the view of many critics. The lack of a proper, blinded, sham-controlled comparison makes it really hard to definitively say the improvements were specifically due to the hyperbaric oxygen itself.
Could it be placebo again, or just the effect of being involved in a study?
Those are exactly the concerns. Without that sham comparison, you can't easily rule out nonspecific effects. So while the authors see this kind of observational or comparative data as somewhat supportive, they conclude that routine use of HBO2 for stroke patients more than 3 months after their event is not justified by current high-quality evidence.
Still experimental then.
Still firmly in the experimental category, yes. They emphasize, again, the critical need for future trials in chronic stroke that incorporate valid sham controls and track patients long-term to see if any benefits persist.
So as we kind of wrap up this deep dive, what's the main thing you'd want listeners to take away about this whole area of off-label HPO2?
I think the key takeaway is really about balancing hope and evidence. Hyperbaric oxygen is genuinely a valuable, life-saving treatment for certain specific approved conditions. No doubt about that.
Yep.
But its application to this much wider range of off-label conditions often rests on pretty shaky ground, scientifically speaking. The evidence is frequently preliminary, inconclusive, or sometimes even negative. And we have to remember that powerful placebo effect, especially with such an involving treatment.
And disentangling that placebo effect from a true therapeutic benefit really requires that rigorous scientific investigation.
Absolutely. The authors make a strong case that well-designed, properly controlled trials, especially those using a credible sham procedure, are essential to figure out if HBO2 genuinely offers specific benefits for these other conditions. Without that solid evidence, promoting or using it widely outside of research raises those ethical questions we discussed.
This has been really fascinating, actually. It shines a light on how important it is to critically evaluate the evidence, especially when treatments can have such a big impact on people's lives and, well, their hopes.
Indeed. It's a complex intersection of science, patient need, and sometimes, unfortunately, commerce.
Definitely. And maybe on that note, here's a final thought for you, our listeners, to chew on. Given how significant these placebo or participation effects seem to be in some of these HBO2 studies, what does that really tell us about the incredible power of the mind-body connection in healing? And how can we, ethically and effectively, harness the power of patient belief and expectation while still making sure our medical practices are firmly grounded in solid, evidence-based science? Something to think about. Thanks for joining us for this deep dive.